Hello friends, welcome back. Um, so this is a video of a 45-year-old lady with the uterus having multiple fibroids and ovaries showing endometriosis. And the uterus is almost 20 to 22 week size, almost up to the umbilicus. So in this case, we are trying to follow a different technique where we'll be stepwise devascularizing the uterus first. The entire uterus will be devascularized in a stepwise manner. So first I'm tackling the physiological additions of the sigmoid colon, because otherwise the bowel will be very close to the uterus. You can already see the ureter moving. So after releasing the physiological additions of the sigmoid colon, I want to directly enter the retroperitoneum, through which I'll localize the uterine artery and the ureter, and I'll be tackling the uterine artery at the origin. I'll be ligating or cauterizing at the origin. So for that, I'll have to completely remove the physiological additions of the sigmoid colon. You can see the infundibulopelvic ligament with the vascular supply lying just below this, and you can see the ureter way below. In this case, the ovaries are adherent to the uterus, but it's not a complete grade for endometriosis because the pouch of Douglas is not fully obliterated. There is still space, but the ovaries have endometriosis. Endometriotic cyst is there, which we can see later. So almost the entire physiological addition has been tackled. Now I'm just opening up the retroperitoneum to enter the retroperitoneum and reach the uterine artery at the origin. So as I said before, in this case we are going to do it in a different manner. We are going to devascularize, stepwise devascularization of the entire uterus first, and then make things simple. Always, I repeat, cut tissues on traction. When you put tissues on traction, new planes open up because carbon dioxide gas goes in and planes open up. So that is the external iliac artery which has been exposed first. You go medial to that once you see it. Now you can see the ureter which has been exposed. Very beautifully exposed ureter. The peristalsis is seen. Once the ureter is exposed, you work lateral to the ureter in order to find the vessel which is crossing that plane, which is a pararectal plane. I'm just cutting the entire round ligament to get more mobility for the uterus. Yeah, I've got more space now. There are no previous surgeries in this case. So that is the obliterated hypogastric. Now if you find the obliterated hypogastric, it's very easy because you can trace the internal iliac artery backward. You can just put that on stretch and you can see the uterine artery pulsating. You can just hold it and put it on stretch. That's another method. This is the paravesical space I'm entering and opening up. Now we can see I'm trying to skeletonize the uterine artery. You can already see the pulsations close to the uterus, close to my atraumatic forceps. The pulsations are clearly seen, and the ureter is below. This is the water under the bridge phenomenon. I'm just trying to skeletonize the uterine artery more so that, because veins will also be coming here. You don't want to accidentally cut the veins because then it will be torrential backflow will be there. Now I'm just cauterizing the uterine artery. You can even take it with harmonic scalpel. I'm just cauterizing the uterine artery, then cutting it with the harmonic scalpel. So the uterine artery on the left side is tackled at the origin. So this vascular supply has been tackled, taken care of. Now what I'm doing is the infundibulopelvic on the left side, I'm just cauterizing and leaving. Advantage of opening the retroperitoneum is that the ureter is right within your sight. There is no chance that you will cauterize the ureter or the thermal damage will be there. The ovary, as you can see, is adherent to the uterus, posterior surface of uterus. So left side, both the vascular supplies, major supplies have been taken care of. I'm just opening the UV fold of peritoneum. I'll try to push the bladder down from this side. Mind you, the uterus has been devascularized by 50%. The vascular supply from the left side has completely gone. And that is a uterine vein which has been exposed. Be very mindful, very careful. It's not going to cause a life-threatening bleeder, but then it will completely dirty your field. So I'm just cauterizing it. That is a uterine vein. So as the right side vascular supply is still there, there will be a significant amount of backflow or oozing if I damage the uterine vein at this point. Once that vascularity also taken, then only the backflow from the uterus will come. So that will stop after a certain point of time, but not now. So putting UV fold on stretch and cutting it. As I said, no previous surgeries, no previous cesarean. So the plane is good. That is the cervix which has been exposed. At every step, realign your forceps to put the tissue on stretch very close to the site where you're going to cut. And that is actually the contour of the cervix. Cervix is ending there. Again, realigning the tissue forceps, putting it on stretch, cutting. With every cut, a new plane will be exposed. Just do blunt dissection and push it, because you're just going to find areola tissue here. So I've taken the bladder to an extent almost till the right side. Now we're going to go to the right side. Here also you can see the ovary is adherent to the uterus. Now I am again opening up the retroperitoneum. The same principles will be followed this side. Open up the retroperitoneum, localize the ureter, find the uterine artery crossing it, take at the origin. So you can see that virgin tissue, virgin plane retroperitoneum which has been exposed there. The areola tissue can be seen. So the round ligament has been entirely cut so that the uterus becomes more mobile. As I'm cutting close, I'm deroofing the retroperitoneum. You can see I'm cutting close to the infundibulopelvic ligament. Searching for the ureter here will be revealed very soon. Okay. So that is the ureter. You can see the peristalsis, and just adjacent to the ureter is the internal iliac artery. Internal, or no, that's the external actually. Internal will be deeper. Once the ureter is localized, you work lateral to the ureter. Ureter, if you can come, entire course is seen. It's crossing at the bifurcation of the common iliac artery. Once you localize the ureter, work lateral to it. Now that is the uterine artery which has been exposed, which is arising from the internal iliac artery. You can see that tortuous vessel which is going up, crossing the ureter. That is a water under the bridge phenomenon. And it is so thick and tortuous and dilated because the uterine size is quite large. And there are multiple fibroids. So you've made a space between the ureter and the uterine artery. It is fairly skeletonized. You can see the pulsations. Now either you can cauterize it, ligate it with bipolar forceps or the harmonic scalpel. So as the uterine artery is inside, I'm just deroofing it, anterior aspect of broad ligament also. It joins with the UV fold. I can see the site where the uterine artery is entering the uterus. So I'm just completing it from this side so that the bladder completely goes down. One more advantage being that the ureter will be lateralized a bit more. Now it's very clear, the entire course of uterine artery is clear. I'm taking it at the origin. As the uterine artery comes closer to the uterus, the dilatation and the diameter is going to increase. So it will be very tortuous and dilated near the uterus compared to its origin. That is a obliterator hypogastric which is continuing. I'm just focusing on the uterine artery. Yeah, I've taken the entire chunk of uterine artery. I'm cauterizing it. The ureter is in my site, I can see it below. So I'm not putting any thermal energy there. The right side uterine is taken. So if you see, left side uterine and the infundibulopelvic ligament is taken. Right side uterine is also taken. I'm just cauterizing again near the uterus. The only vascular supply left for this uterus is the right infundibulopelvic ligament. So once we take that also, the entire uterus is devascularized. So this is what is stepwise devascularization of the entire uterus. After that, cutting the uterus will be like you're cutting a devascularized tissue. So this is the last vascular supply of the uterus, the right infundibulopelvic ligament. Here also the ovary is adherent to the uterus. So anyway, it's a case of TLH-BSO. So with this, once you see the uterus, you'll understand. See the uterus. Entire uterus is devascularized. It has lost its color. Only what is accumulated inside, that will be left, the blood. So again, just revising and seeing the ureter, because now I am going to cut the infundibulopelvic ligament. In case of endometriosis, always the ureter will be pulled medially. So the ureter can be seen, external iliac artery can be seen, internal iliac artery is below that. So now I'm just cutting through. Yes, the infundibulopelvic ligament has been cut. It was cauterized earlier. I kept the infundibulopelvic of both sides just in case to understand the anatomy and prevent hypermobility of the uterus. Otherwise, what will happen is the uterus will keep on turning when all the supporting structures are cut. Now I have ureter in my site and I am cutting medial to the ureter so that there is no injury. You can see that there is some bit of addition and fat deposition there. That's because of the endometriosis of the ovaries. We are moving more towards the uterosacral ligament now. Here is the plane of the uterines. You can see the uterine vein which has been cauterized earlier. You can see it there. I'm just cauterizing again because what happens in large uteruses is that how much ever you devascularize it, there will be significant amount of backflow. Even up to 500 ml of blood can get accumulated in such large uterus, 500 ml or more. So if you don't cauterize this again, what will happen is there will be significant amount of backflow which is going to make your field messy. It's not going to bleed or cause any problems, but the field will become messy and you lose your planes. So left side has been completed. We are coming to the right side. We're cutting the cauterized part of the infundibulopelvic ligament. See, that's the backflow I was talking about. In spite of getting the entire uterus devascularized, there will be still some backflow because the uterine size is large. We'll just stay more or less close to the uterus, but not very close. In this case, both sides, the ureter is right in front of our eyes, so we are safe. If you go too close to the uterus, there will be a lot of venous plexus will be damaged and there will be backflow. That's the venous plexus you can see clearly. I'm just cauterizing again. So the cauterized part of the uterine veins is being tackled. And the uterine artery also will get cut again here because the entry point of the uterine artery into the uterus. Again, revising the bladder so as to delineate the contour of the cervix. This revision of bladder has to happen till the point where the vault is opened up. Now I have just put in a vaginal tube to delineate the fornix, and I'll be cutting onto the vaginal tube. I'm feeling the vaginal tube and then cutting with that as a reference point so as to open up the vault. We will expect some sort of vascularity here because of the cervical artery and also the collaterals. Be prepared for that. Yeah, now the vault has been opened up. That is a vaginal tube which we have inserted vaginally. Once it's opens up, then you can just follow the borders of the cervix so as the length of the vagina is preserved. Here, just to be doubly sure, what I've done is I'm just cutting through the cornual structure here so that the ovary is lateralized and I stay in a plane which is medial and away from the ureter. This is a double precaution, that's all. You don't need to do it. Once the ovary is opened up, you can see the endometriotic fluid which will come out. Yeah, that's it. The endometriotic, the chocolate colored material which is hiding in the ovarian ligament and the ovaries. So finally we'll take the ovary separately on this side again, even though we have cut the infundibulopelvic ligament. We'll tackle the ovary finally. Then we cut through this plane and reach the vault, then complete the hysterectomy. The right side, the ovaries have already been taken. That opening up of the vault is a reference point. You can cut towards it. Yeah, right side also you can see the ovaries, it's adherent there. Both ovaries are more or less adherent to each other. Somehow, surprisingly, the pouch of Douglas is not completely obliterated. The bowel part is spared. You have reached the uterosacral ligament now. With cutting this, the uterus will become quite free and mobile. We have the vault, opening of the vault as the reference point. So we'll cut towards it to be in the safe plane. The ureter will be lateral. Put the uterus on traction, follow the cervical edges, as you can clearly see, and just cut. If required at this step, you can just revise the bladder again, so that the bladder is pushed down comfortably down, and you have fair amount of vault tissue or the vaginal tissue there to suture. Sometimes if you don't revise the bladder well, what happens is the bladder stays very close to the vaginal tissue. And after the uterus is delivered, then it's difficult to revise again, because then you won't get a very clear plane. The vaginal tissue will retract. So it's better to do at this step, at this stage. The uterus, as you know, it has been entirely devascularized. We're just following the demarcation of the vault, the fornix here, based on the tube we have inserted, and just cutting with that reference. Here, if you see, the bladder can be revised again. So in this case, just wanted to demonstrate that technique where if you are in doubt, if you want to minimize blood loss, if the uterine size is large, or if it's endometriosis, what you can easily do is that you can completely devascularize the uterus and then proceed to the hysterectomy part. You have seen in this case, there was hardly any blood loss. Hardly any blood loss at any step, even when you are cutting the uterine artery or the vein or any other structures. Hardly any blood loss in this case. This is one technique which you can use to minimize your blood loss in cases where the uterus is very large and or rare blood groups, or you're expecting a lot of blood loss and all. This technique will be useful. So the hysterectomy part is complete. Now we'll just taken the ovary also, and the uterus will be delivered from down by manual morcellation with knife.